Good afternoon, everybody. Thank you very much for joining us on the last day of this high-yield postgraduate course of the section of hematology of the UPPGH, which brings you the red flags of emergent hematologic conditions. I am Dr. Maria Claudia Chavez, and I was invited by the scientific committee to share my knowledge on the basic approach in the diagnosis and management of lymphoma. My objectives for this short lecture are as follows. Review the different aspects of lymphoma, definition, risk factors, and common symptoms. Differentiate between Hodgkin's lymphoma and non-Hodgkin's lymphoma. Discuss the diagnostic workup for lymphoma. Review the staging classifications for lymphoma. And lastly, discuss the treatment for lymphoma and prognosis of patients with the disease. To help us understand lymphoma, please allow me to share the stories of two patients. Our first patient is JS, a 22-year-old female who presented with bilateral cervical and axillary lymphadenopathy, which progressively grew in size in the course of 8 months. This was associated with low-grade fever, easy fatigability, and unintentional weight loss. There was no increased bleeding tendencies, cough, colds, abdominal symptoms, or changes in bowel habits. On physical examination, there were enlarged lymphadenopathies at the cervical, supraclavicular, and axillary areas, with the largest being at 10 to 12 centimeters in diameter. However, there was no palpable inguinal lymph nodes, as well as a palpable liver or spleen. Laboratories on initial consultation revealed normal results. Our second patient is PB, a 50-year-old male who also presented with a history of unilateral cervical lymphadenopathy of 3 months duration. This was associated with low-grade fever, easy fatigability, generalized body weakness, early satiety, loss of appetite, and unintentional weight loss. Like JS, there was no increased bleeding tendencies, cough, colds, abdominal symptoms, or changes in bowel habits. On physical examination, there were prominent lymphadenopathies at the left side of the postauricular and posterior cervical areas, with the largest being 4 to 5 centimeters in diameter. There were no other palpable lymph nodes, as well as a palpable liver. However, unlike JS, his spleen was markedly enlarged at 10 centimeters below the left subcostal angle. Initial laboratories showed mild anemia on CBC with a hemoglobin of 121 grams per liter, as well as slightly elevated blood uric levels. All other blood results were normal. So we have two patients, JS and PB, who both presented with lymphadenopathy. Given what we learned in the previous lecture on enlarged lymph nodes, it would be safe to surmise that these two patients may have lymphoma. Before we move on with their stories, what is lymphoma? Lymphoma is cancer of the lymphatic system. It is composed of lymph nodes, which are responsible for the removal of excess fluid in the body, as well as produces the lymphocytes. Lymphoma cells are derived from abnormal lymphocytes, which multiply and collect in the lymph nodes, eventually impairing the immunity system if left alone for too long. The most common risk factors associated with lymphoma are age, with the younger and older population being the most affected in a bimodal distribution, male gender, ethnicity, with Caucasians being more affected than Africans and Asians, the presence of autoimmune disorders such as rheumatoid arthritis and celiac disease, immunodeficiency conditions such as HIV and AIDS, previous infections with human T-cell leukemia or lymphotropic virus, H. pylori, hepatitis C, and the Epstein-Barr virus, exposure to certain chemical and radiation, such as pesticides and nuclear radiation, obesity, and of course, family history. The most common symptoms seen in patients with lymphoma are the following: enlarged lymph nodes, fever and chills, cough, weakness and fatigue, unexplained weight loss, loss of appetite, stomach pains, night sweats, difficulty in breathing or shortness of breath, pruritus or rashes, and splenomegaly. It is worthy to note that a lot of the symptoms on this list were experienced by our two patients. Given our patients' rather ominous history and physical findings, it is rather clear that we may be dealing with lymphoma. This begs the question, are we dealing with Hodgkin's lymphoma or non-Hodgkin's lymphoma? The distinction between the two should be made early, as this greatly impacts the treatment and prognosis. This table highlights some of the key clinical differences between Hodgkin's and non-Hodgkin's lymphoma. I would like to point out that in Hodgkin's lymphoma, the characteristic cells are the well-known Reed-Sternberg cells. It generally affects the younger population. These symptoms of fever, night sweats, and weight loss may be present. It is usually diagnosed in the early stages. It usually involves the peripheral lymph nodes, and prognosis is quite excellent. In contrast, in non-Hodgkin's lymphoma, it is mostly seen in the older population. It is usually diagnosed in the later stages. It usually involves the central lymph nodes. Involvement of extranodal sites such as the spleen and bone marrow are fairly common, and prognosis is unfortunately generally poorer. This table highlights the different types of Hodgkin's and non-Hodgkin's lymphoma. For Hodgkin's lymphoma, the most common type is the nodular sclerosing type. In non-Hodgkin's lymphoma, the most common would be diffuse large B-cell lymphoma, or your DLBCL. To diagnose lymphoma, only a lymph node biopsy is definitive, particularly that of an excision or incision biopsy. Although a fine needle aspiration and a core needle biopsy are often part of the initial evaluation of any adenopathy, neither will provide the adequate tissue to make the diagnosis because of the need of an intact lymph node architecture and the identification of the needed cells. A core needle biopsy is only reserved when the identified lymph nodes are deep in the chest or abdomen or in other locations that are difficult to reach with an excisional biopsy, or if other medical conditions prevent the undertaking of an open lymph node biopsy. A fine needle aspiration biopsy is only done for relapse disease and should never be used for the initial diagnosis of lymphoma. Other diagnostic workup that may be done include a CBC, LDH levels, and a comprehensive metabolic panel. Hepatitis panel and HIV testing may also be done, especially when contemplating certain types of non-Hodgkin's lymphoma, such as Burkitt's lymphoma. Cytogenetic analysis, immunophenotyping, and biomarker and genetic testing are usually done for prognostication and treatment guidance. Imaging studies, particularly whole body CT scans and PET CT scans, should almost always be done for staging purposes, as well as surveillance monitoring post-treatment. Bone marrow studies, lumbar tap, and fluid sampling of the pleura or peritoneum are also alternative examinations that can be used in the diagnosis of lymphoma, as well as for staging purposes. In staging lymphoma, two classifications are used. The one that most of us are familiar with is the classic Ann Arbor staging. Developed in the 1970s, the Ann Arbor staging uses the location of the involved lymph nodes. Stage 1 is the involvement of a lymph node region or a single extra lymphatic organ or system or site. Stage 2 is the involvement of two or more lymph node regions on the same side of the diaphragm or localized involvement of an extra lymphatic organ or sites. Stage 3 is the involvement of lymph node regions or structures on both sides of the diaphragm. And our stage 4 is the diffused involvement of one or two extra lymphatic organs. Additional substaging variables is based on the associated symptoms present or experienced. The letter A is used to denote a symptomatic disease. B indicates the presence of notorious B symptoms of fever, night sweats, and weight loss. E indicates the involvement of a single extranodal site contiguous or proximal to a known nodal site. And X denotes bulky nodal disease, which is defined by the presence of lymphadenopathy of more than 10 centimeters in diameter. The second classification is the Lugano classification. With the advent of more advanced imaging modalities such as CT scans and the PET-CT scan, the Lugano classification is the more modernized and updated version of the Ann Arbor staging system. This is the classification that is currently being used for both staging and treatment reassessment purposes. But as you can see here, the description of each of the stages are similar with that of the Ann Arbor classification. Going back to our two patients, on repeat laboratory workup, JS was still noted to have a normal CBC result as well as normal LDH results. She underwent a cervical lymph node excision biopsy wherein there was a typical lymph node or lymphoid proliferation with the presence of Reed-Sternberg cells. Immunohistochemical staining was positive for CD30, PAX5, and MUM1. CT scans of the chest and whole abdomen showed multiple lymphadenopathies. However, it was confined to the upper half of the diaphragm with no noted organomegaly. PB, on the other hand, still had mild anemia on repeat CBC and had an elevated LDH result. He also underwent a cervical lymph node excision biopsy wherein atypical lymphoid proliferation was also seen. Immunohistochemical staining was positive for CD20 and BCL2, but negative for CD3 and CD30. CT scan images of the chest and abdomen showed multiple lymphadenopathies on both sides of the diaphragm, as well as marked splenomegaly. Given this data, JS was diagnosed as classic Hodgkin's lymphoma, nodular sclerosing type. Her staging, based both on the Ann Arbor and Lugano classification, is stage 2, as her multiple lymphadenopathies were confined in the chest area. However, as her largest lymph node was measured at more than 10 centimeters, she is given the subclassification of 2X. Meanwhile, PB was diagnosed as non-Hodgkin's lymphoma, follicular lymphoma, with a staging of stage 4 for the Ann Arbor classification or stage 3 for the Lugano classification, as his lymphadenopathies were seen on both sides of the diaphragm and there is splenic involvement. Prognosis is very important in the management of disease, and lymphoma is no different. Given the clinical and behavioral differences of Hodgkin's and non-Hodgkin's lymphoma, it follows that there are two different prognostication criteria as seen in this table. For JS, as you may recall, did not fall into any of the criteria. Hence, her score is 0 and her prognosis is quite excellent. PB, on the other hand, had elevated LDH levels, is classified as stage 3 or 4 disease, and has splenic involvement, which gives him a score of 3, which is not as favorable as one would hope. Treatment for lymphoma is pretty straightforward. As seen in this table, both Hodgkin's and non-Hodgkin's lymphoma employs chemotherapy with or without radiation therapy. RT is usually given if there is presence of bulky disease. ABVD, which consists of doxorubicin, bleomycin, vincristine, and dacarbazine, is the chemotherapy of choice for Hodgkin's lymphoma. Other regimens like the Stanford V and the different workup versions may also be employed if ABVD cannot be used initially or if the patient relapses after ABVD treatment. Historically, R-CHOP is given in patients with non-Hodgkin's lymphoma. In many cases, this is still being used as the first-line treatment. However, given the relatively poor outcome of many non-Hodgkin's lymphoma, many specialists resort to using the newer agents, such as the alkylating agent bendamustine, the monoclonal antibody brentuximab, or the targeted therapy venetoclax with or without rituximab as first-line treatment in an attempt to improve outcomes. JS completed chemotherapy with the ABVD protocol for 4 cycles. In addition to this, she also underwent targeted radiation therapy due to the fact that she has bulky disease. PB is currently undergoing chemotherapy with rituximab and bendamustine for a planned 6 cycles. He is on his 4th cycle right now. Currently, they are both doing well with marked improvement in both their symptoms and in their lymphadenopathies. So what happens after treatment? Always remember that the management of our lymphoma patients do not end on completion of their chemotherapy. Interim reassessment and surveillance monitoring, usually with the aid of both laboratory testing and imaging studies such as PET-CT scan, is the key to good patient outcome and survival. These are my references. Thank you so much for listening, and again, good afternoon to all.